Hi, good morning, everyone, and thank you to IPH, Dr. Devadasan, the whole team at IPH, ITM, all the government officials who are here, and the entire audience for this opportunity. The title of this presentation is The Quality of Care in Obstetric Services in Rural South India, and it's evidence from two studies in the same area, in the same geographic area, over a 10-year period. The research was undertaken by Belakut Trust, where I used to work, and I still collaborate with Belakut Trust. I'd like to also acknowledge Saraswati Ganapati, who is the director and who was key in this research, as well as Paneen Karachiwala. The objectives of the presentation today, and I made a similar presentation at a small meeting we had yesterday, so I apologize to those of you who were there. I think there are only a few, but small changes, but a lot of similar things I'm going to say today. The objectives are to compare changes in pregnancy and delivery services over a decade in the Taluka Ramnagaram district. The first study was in 96 to 98, and the second one between 2007 and 2009. And the analysis was done to identify the gaps in the quality of services currently being delivered to women during pregnancy, delivery, and postpartum, and finally to make suggestions for how the gaps may be addressed. I don't want to spend too much time on the methods. I'm happy to answer questions about this, but just briefly to say they were both prospective studies. The first one had a random sample of villages. The second one had a mix of random and purposive sampling. And we interviewed women in the antenatal stage as well as the postpartum stage. The first study had a sample size of 388 who completed the study, and the second one, 608, completed the study. So very quickly to move to the findings. In antenatal care, we do see an improvement in care. It has risen dramatically to 83% from 56% in the 10 years in terms of contact in the first trimester. The number of antenatal visits also has gone up from 6% to 64% of the women having received more than 4 visits or contacts with a healthcare provider. We had some information on the content of care, which is one of the aspects of quality. And from the first study, we had information showing that 57% of the women had their blood pressure checked at least once in pregnancy. In the second study, we had a little more information on this particular aspect of antenatal care. And you can just see that there's just tremendous variation. It's not very consistent. Certain things are being done to, let's say, the majority of women, and this data comes from the most recent visit they had in the 3rd trimester. And at the same time, there are quite a few very key components of care that are lacking, and not just some of the tests, but also very critical things like advice. And there are so many things to educate women and families on, and that doesn't seem to be happening. Sorry, I think the last part of it got cut off, but it says plan to deliver at home. In the first study, 87% of the women planned home deliveries. That dropped to 10% in the second study. Interestingly, we asked the women in the second study where they might deliver if they were pregnant again, and almost 15% of them said they would like to deliver at home. So this just, I know institutional delivery is a very important goal for the government, but there will always be women who choose to deliver at home, apart from women who can't make it to the institution in time. Planning for problems, this was something we looked at in the qualitative data for both, so I don't have concrete numbers as such, but it's low, and it was low 10 years ago. It continues to be low, partly because it's seen as prophetic. If you feel you may have a problem, what should I do? If I have a problem, you're more likely to have a problem. That mindset is very strong, and I don't think the health system and providers have really done anything to address that. One of the very interesting findings from the first study was that 30% of the women changed from their anticipated place of delivery to where they actually went. And we measured this in the second study and found that it had not changed much. 33% of the women also switched. And over 80% of them did this during labor. So it's just, when you start to think about how stressful that might be when a woman is in labor, to then say, well, we're not going to go where we thought we were going to go, we have to go somewhere else, where should that be? The reasons, and here I've left out switching due to a referral. If you add that, it goes up to 43%. And the reasons for switching were because a facility was closed or because people were worried about a complication, not having adequate transport. Institutional deliveries rose dramatically to 82%, and here the Taluk hospital is actually bearing the burden of the caseload, and this was something that I think this is an important metric to measure at the district and Taluk levels. When we spoke to the health officers, they really didn't have an idea of the estimates of deliveries they expected in a given time period, whether it was a quarter or a year. What percentage of deliveries do you think are going to happen at the PHCs or at the Taluk? And they really weren't aware of what those might be, so it makes you wonder how this information goes into planning, and if it does so at all. A&M attendance at home delivery, this is very important. We found that in the second study that while there were only 16% home deliveries, only 17% of them were attended by an A&M. The rest the majority were with a lay attendant. So that has come down. And women did say to us that, the A&Ms have told us we need to come to the institution. They may not be available to come home. Oxytocin, this was a disturbing finding in the first study. Oxytocin being used intramuscularly, of course, in home deliveries, also happening mostly with the A&M, by the A&M, also in the second study. We had information in the second study on institutional delivery, oxytocin in institutional deliveries, and 23% of the women received oxytocin for labor augmentation, and that was intramuscular again. So that's in contravention of most guidelines that I know about, and it's a cause for concern. We tried to look at whether there's any active management of the third stage of labor, and we really didn't find much of that happening. Birth weight, of course, recording has gone up. Length of stay, this is something that came up in yesterday's meeting as well, and it's very short. Hasn't changed much again over the decade. 62% of the women left within 6 hours, and the same percentage, left early among the women with low birth weight infants, and that's very disturbing. So, it points to a complete lack of any kind of risk assessment happening. Postpartum newborn advice, again, 50, 60% is just not good enough in this regard, and you can see that it may not be statistically significant, but the women with low birth weight infants were actually a smaller percentage received advice. Perinatal deaths have reduced, no doubt, but we did a verbal autopsy of these, and we're analyzing them currently. And again, a lot of missed opportunities there. Most of the neonatal deaths in study 2 were institutional deliveries, and almost half of those neonatal deaths happened at home. So they delivered in an institution, they went home, and died at home. And I think we saw that only 4 of the 14 received any advice on discharge about the baby. Postpartum visits, very, very weak area within the health delivery system. It has gone up, the prevalence of contact with a provider has gone up, but the content of care is almost nil. It's really mostly for immunization for the newborn. There was really nothing for the woman and for the health of the woman. Very quickly, I just want to touch on the cost of care, which is a very, very important aspect of quality and not talked about enough. We found the costs to be really high. In the antenatal period, The median expenditure was about 150 rupees per visit for a government provider and 250 rupees for a private provider, and the bulk of that went for medicines. In the intrapartum period, we found that the highest expenditure category was for provider payments. And you can see the median figures there, 1,000 to 300 to 1,300 for normal delivery in the government institutions, 4,000 in the tertiary government institutions, and the same median for private. C-sections were just, catastrophically high for poor families. Very quickly, I'm not sure how much time I have left, but women's perceptions. We had a whole series of questions, and I've just, pulled out a few. 3 minutes left. I'm not going to go through these in detail because of lack of time, but, women are not perceiving that care is safe, that it's supportive, that it's friendly, that it's comforting, that it's respectful, all across the board. And in general, private institutions are performing a little bit better, but not great. If you look at the provider did not speak with respect, for example, 21% of those who went to a private provider said, found that to be true. And we can expect a lot of underreporting in these answers, in these responses. Very briefly, family members are key. They really take most of the decisions, we know that. Another thing that doesn't seem to have changed much in terms of the health system, recognizing that there are a lot of traditional local beliefs about disease causation, and that really influences care seeking, and that's something providers have to take into account actively. This is just a quick summary of what I showed you. Antenatal coverage has improved, but it's inconsistent in content. Home births have dropped, but more of them are, a greater percentage are being attended by lay people. There's little change in switching, in that switching behavior. Oxytocin use is still being observed. The duration of stay is short. Doesn't seem to be change in provider communication, and that's something I think we have to really address now very strategically, very systematically, and not to say, well, it's just some soft skills training. I think there is a science and an art to this, and we have to go into that in detail. Conclusions and recommendations. These are really not overarching, conclusions about maternal care. They really relate specifically to the study, the two studies, and the findings from the two studies. And this is just a microcosm in contrast to what Professor Malvankar shared, which was a very useful picture of the broader trends. This is just a small taluk. I mean, it's a large taluk actually, but it's just a small part of India and what's happening over 1 decade. So basically, the availability of 24/7 PHCs is much talked about, not really happening. It is critical. 25% of the women who switched did so because the PHC was closed. Checklist for providers on specific components of recommended care. I can't prioritize this enough. Too many critical things are being left out. And if you add this to the lack of continuity of care, women see multiple providers in antenatal care and switch during delivery, many of them. I think this makes for a very, it just adds to the risk. Emphasize communication. This is related, informing women and families